I was like, well, you wouldn't do anything.
Did he get frustrated?
I was telling him. You want your toes?
Okay.
Yeah, okay, you're
You
fine.
guys like this room better?
Yes.
No, yes, okay.
Yes.
And we have an exam. We are on the same exam schedule, so they take the big room because there's only one person to proctor. And then we'll be in here and then vice versa. So tomorrow when we have our exam, we'll be in 107. That way it's just easier to spread out so I can see what's going on. Yeah,
We have to wear our line.
if you want to. Wear whatever you're comfortable in, I'm fine. Okay, so this week, this is my favorite week. This is my favorite topics. I've been a ER nurse for longer than some of you probably been alive. Over 20 years, and this is my favorite. I love the heart, I love shock, I love trauma, I love all those type of things. So, I don't have a lot of videos that go with this, but I have lots of stories. So if you want stories, let me know. If you want to just get through material, that's fine too. But we're gonna cover the basics of shock. If you look at your study guide, there's a pretty lengthy list of objectives. I'm trying to wean you off of that test plan where you've got like, I need 12 questions on this. I'm trying to give you more specific things to look at so that you can kind of check your knowledge. So if there's more on this study guide than there are previously, and that's because I'm trying to get you to like focus on those and less on just basic numbers, right? It'll help you with your own. So for the shock portion, it comes out of your book. For the trauma portion, some of it's in the book, some of it is like information. So if it's not, I don't have a page number that correlates, we'll just skip that. There will also be a, lecture. I say lecture, but you know what I mean, like a little recording on mass disaster and emergencies. So that's gonna cover, the feedback that I got from students who took the NCLEX last this year was that they all got some type of questions on bioterrorism or catastrophic natural disaster kind of things. So we're gonna include some of that in it, so at least you have heard it. So at least you have some things, and that does come out of your book. I believe that's chapter 7. So lots of information today. None of this is on your exam, but it's all gonna be on the next exam. The next exam's coming up. So if you haven't started reviewing your material, kind of as you go, this is your invitation to start, because we're gonna kind of pick up the pace. So tomorrow we have one exam, in 2 weeks we have another exam, and in 2 weeks we have another exam, right? We're gonna kind of crank these out. That gives you time to kind of dig into this content, kind of focus on it, and get a good head start, kind of get some understanding, and everything kind of builds. Okay, so questions about the exam tomorrow? I'll give you like 5 minutes to ask the questions before we start. What's that? There's no math. There's no math. Paper and pencil, old school Scantron, you fill in the little bubbles. 50 questions, there are 2 1-point bonus questions, right? So you can have up to 2 bonus questions. The bonus questions are usually a little bit more nitty gritty, so if you earn them, you earn them. There are 2 on each. I did want to tell you that we had an addition to the calendar on November 21st. Dr. Baca is going to come and speak to our senior class. So it's going to be the end of our mental health. It actually comes the day after our mental health review. And he's got some good information. So he is actually just coming just for our students. We'll be in 107. And exam 5 will not have 2 bonus points on it on that exam, but you will get 2 bonus points if you go to Dr. Baca's lecture, which will be about an hour. So I think that's fair. If you, it's a review. He's going to talk about substance abuse and the mental health component with that.
What day is it again?
The 21st of November. Yep, it's right toward the end. It's right, Jordan is gonna, sorry, Mrs. Liggett's gonna do the mental health review. We're gonna do a thing on grief loss and mental health review. Then the next day, there's gonna be an exam, and then he's gonna come about 10:30 and we're gonna have a discussion. So after your exam, you're just invited to stay. You get 2 bonus points on your exam 5, and I will tell you more about that. Just for your calendar though, kind of keep that on the horizon. Questions on the exam for tomorrow? If you're an accommodations person, you're gonna go early. If everybody else, we're gonna meet at 9, and there you have an hour and 15 minutes to take the exam, and then when you are done, we are gonna run them, but don't expect your grades to be posted until later in the afternoon. Because we've got other things we have to get done, so feel free to go to lunch, do whatever you're gonna do, but they'll be posted later. Yes?
Is your select all apply all or nothing?
Select and apply are not partial credit because on the NCLEX, you only get partial credit if they are greater than 6 answer options, and we have 5 bubbles. Okay, so there's no credit. Each question is worth 2 points, except for the bonus, which is 1 point. So 52 questions. If you don't get the bonus right, it does not count against you. If you do get them right, then we add them at the end. If there is an issue, a problem with a question, we will hand grade individually. So, but overall, I think we do a pretty good job of making sure we take our time with it. Anything else? Are you nervous? A little bit? Okay. Did that quiz kind of amp up your studying a little bit? A little bit, okay.
Is that what it's gonna look like? The three, like, you can't do drop downs on paper, right?
We can't do drop downs on paper. So the questions are either fill in the blank where you have the answer option, multiple choice. There are multiple choice, the true form. There are select all that apply, and select all that apply and the ones with a drop down or the fill in the blank. There's only 20% of the questions that are not your traditional multiple choice because NCLEX is 20% next gen. And so we try to mirror that.
You're gonna give the answer options that we
Yes.
fill in.
Yeah. We tried doing fill in the blank. We tried doing fill in the blank for math. We tried it with the Scantron. It's a nightmare and it was really difficult. So we just made it real easy. And then we'll do all the fun stuff on the quizzes where you get practice with the next gen. Everybody knows what next gen is when I say that, right? Next gen are the NCSBN are the company that does the test plan for, or does the NCLEX for the boards. And so they redid the test last year, 2 years ago, to include what they call next generation style questions. And those are the ones that you'll see. They'll give you like a portion of the patient's chart and then you have to answer questions based on it. Or there's the drop down, or there's the like matching where you like draw the line. They do the bow tie. What they found was that the traditional multiple choice questions were really easy for some people and really hard for some people. So if you're a super great test taker, multiple choice, you did fine. For other people, just because you don't do well on a test doesn't mean you're not a good nurse. So it did some different type of learning where like when you take your Kaplan, where they got those questions that are not your traditional ones, and those are designed to see if you are safe. So I went to a webinar where they were teaching us how to use them, and we always have medication questions. We always have medication questions on every exam. What they did was they would show you a snapshot of the MAR, right? Patient information at the top, all the stuff, and then the medication. And so at the bottom, it said, you know, what's the appropriate dose for this patient, right? Typical question. But if you went back and looked at it, the patient's allergy was what they wanted you to give. So the answer was, no, I wouldn't give any, right? That's the type of thing where maybe you're not good at math, or maybe you're not good at multiple choice, but in a format like this, which is what you're doing in real life, are you going to be safe to practice? So 20% of the questions you will get on your board will be that type of safety thing. And then the rest are multiple choice to kind of balance it. So that's what we try to do with our exams to kind of get you ready. Make sense? We try. Like I tell my kids, you don't have to understand the reason, but trust that I do. So I tell my kids all the time. All right, we're going to talk about shock. And I love shock, and it's a great topic, and you're going to see it all the time. And you're going to try to prevent it. So before we get into shock, we're going to have to kind of look back at those terms, make sure that you understand what they are. Is that better? You see better? Okay. So if you still are struggling to remember what cardiac output is, or what mean arterial pressure is, or what stroke volume is, I invite you to go back and look. Bottom line, we have to have a MAP of 60. Otherwise, our organs don't get the oxygen delivery that they need. Okay. So our goal is to keep it above 60. So what happens in shock is that our tissues, our organs, our cells don't get enough oxygen, and that causes an issue, right? And it causes hypoxia, and we know hypoxia will eventually lead to ischemia, and ischemia eventually leads to death, necrosis. So what happens is the body's not getting what it needs and it shuts down. It just depends on how far we're shutting it down, okay? So we can maintain with a full tank, right? And all our organs are perfused. We can even maintain with some decrease or body will compensate. When it gets to the point where we're not keeping the tank full even halfway, we have a problem. So it's rapidly progressing, it's life-threatening, and in order to figure out what it is, we have to figure out what's causing it so we know how to treat it, okay? Early detection is our #1 priority with shock because we have to know what it's doing, okay? I love this kind of easy to look at picture, okay? So this is not in your book, but I geek out over this stuff and I love it. And I think this is a really easy way to understand. So basically, if you look at the body in 3 parts, we have our blood volume, which is our tank. We have our heart, which is our pump, and then we have our periphery. We have our organs and our vessels, and everything works together in a closed system and it goes in a big circle, right? This is what we want it to look like. So anything that has to do with a disruption of this cycle is what's going to lead to shock. So keep this in mind of what the normal one should look like. And then each shock that we talk about, I'm going to show you where in the process we have the problem, right? So if you're a visual person, this kind of helps. And yes, there is a lot of pathophysiology in your book. And if you would love to read it, it does make a lot of sense. But for ease of understanding, we're going to go this way. Okay, so we know mean arterial pressure is what actually triggers the body to go into shock. So what can cause that is something drops cardiac output, something keeps the circulating volume not back where it should be, or something has to do with the periphery. So if those tie in very much to the tank, the pump, and the vessels. So cardiac output, okay, circulating blood volume, or periphery vasodilation. There's your 3 parts. So here are the stages. The stages are the same no matter the type of shock. They just look a little different, okay? We have an initial stage of shock. Now, my teaching, learning, every resource I have has 4 stages of shock. If you look in your book, it says 3, but part 1 has 2 parts, right? So we're going to talk about 4 stages of shock. We have the initial presentation. We have a compensatory. That's where the body's changing and it's still able to maintain what it's doing. We have the progressive, which is very dangerous. And then you have irreversible. This is even if we are doing all the right things, if we catch you in this stage of shock, your body cannot recover. Your organs have been too stressed for too long. There's too much tissue death and it is not survivable. Okay, so here's a nice table. Spells it out as well. We have the initial, compensatory, progressive, and then you'll notice at the refractory stage or the irreversible stage, it just says impending death. That's it. Okay, so there's your progression. If you like charts, there's a good way to get started. You can kind of go back to it. So let's talk about the initial causes of shock or the initial presentation of shock in this stage. We're not going to see a whole lot of change in vitals. Right? We always think vital signs change and that's how we know when to act with our patient, but it's not. Vitals actually change later in our progression, okay? So we're talking like less than 10 of our blood pressure, right? Less than 10 of our MAP is gonna drop, slight drop of circulatory volume. So less than 500 mLs, right? Less than half a liter is where we're looking at. Maybe a little increase in heart rate. Cardiac output actually goes a little higher. So this is what we would see. And unless we were looking for it, we might not even pay attention. We might not even notice that they're actually in shock, okay? Because the body's covering so well. Then we have the compensatory, but the non-progressive, right? That means that we're compensating pretty well. We notice our MAP's falling now, 10 to 15, okay? Still above 65, still perfusing our organs for the most part, but we're having some more blood loss. Now we're at about 1,000 mLs or 1 liter saline bag. Okay, now we're seeing the blood pressure starting to fall a little bit, but it's still perfusing, right? The body's compensating, so we have no cell damage, right? So if you're looking for it, you can see, yeah, we've got some changes, but it's not going to be anything that is going to not be overcome. You know what I mean? Does that make sense? Yes.
How quickly can you see that MAP decrease, or does it depend on the condition?
Depends on the condition. We'll get into that. Yeah, if they're gushing, right? If they have an abdominal trauma, if they have hemorrhage, if they have a severe like DKA, massive dehydration, you're gonna see it drop pretty quickly. Also, you might not see initial, your patient might come to you, you might get report on your patient and they're already in this stage. So you might not, it might be a condition where you're not watching it fall, but like, boom, here you go. You walk into the situation, what do you do? Okay. These are the reasons why we're able to maintain, okay? And I apologize, the colors are wonky only because like I had to find ones that showed up, so I couldn't use like my normal colors. But the whole body works together. You got your nervous system, right? Your sympathetic nervous system. That's where you get your adrenaline, your norepinephrine and your epinephrine. You got your kidneys, that renin-angiotensin response. We talked about that with the cardiac, right? About how it signals the body to pull more in to the circulating volume. Your hypothalamus, right? That does mitigation. Oh, I'm sorry. Is there? Open the door. We can have bugs like wasps that come sometimes. Corey's got it. You can leave that open if you want. I don't think he'll bite much for now. Sorry. Okay, and here's what they all try to do. What they try to do, all of these first four, they put everything into your capillaries so your blood volume goes up, right? Because all those things work to fill the tank back up so that it can circulate, okay? Right here, it only works for a little bit. Oh, he's got his shoe off. He's really into it. He's gonna get it.
You said the first four we don't.
These four. Right, all of these, what they want to do is they want to get their capillaries full of blood.
There we go.
So that we can keep that pump system moving, okay? Right. Here's the problem though. These work, but because of these four things at the top, if we stay in that state for too long, what we did to fix the problem actually makes a new problem. So we say shock perpetuates shock, right? What that means is that if we're clamped down, if we are rerouting, if we're pulling things in, at some point, it's not gonna be enough, right? And that's gonna cause other problems. And that's where we end up with this is third stage, that progressive. Okay, this is a medical emergency. If they are in the third stage of shock, okay, we're talking we've lost up to half of our circulating volume. That's a big deal. We have a decrease in 20 or more of our MAP, or our mean arterial pressure, and we are no longer able to get the fluids and the blood and the oxygen to our tissues. This is bad. This is really bad. Okay, so when we talk about that shock perpetuates or shock, we are going to be constricted now, right? We wanted to fill our vessels full, and we've got that adrenaline, we've got our sympathetic nervous system, we're doing all these things, but now we're constricted, which is more limiting where we're sending our oxygen. So now we have acidosis. We've got that renin-angiotensin system, which has brought everything in, all of the salt and the water. But now we have those cells that are overfull. And so now they're bursting and we have all their content spilling out. And now we have high potassium because of it. Okay. Now we have our brain and our heart that are not getting what we need. And so we're becoming more hypoxic. Okay. The more we squeeze to get that blood back to the heart to pump out, the less blood we have going other places. So you think of your head, your trunk, that is where your body is going to protect your brain, your heart, your lungs. Does not care about your kidneys, does not care about your fingers and toes, does not care about even like your arms and legs, right? It's everything is preserving this essential function, right? This is what we have a big problem with. When you see on the news, the people who have strep, or the people that have sepsis, or the people who have COVID that no longer have arms and legs, they had to have everything amputated. It's not because of essentially COVID caused you to lose your leg, right? Unless there was a clot or something. It's because your body responding to whatever that trigger was, went into shock, and in order to save your life, your body shunted blood inward and we lost all the periphery. Okay, so think about that when you hear people who have lost different limbs or different fingers and toes and things like that.
Is that because of the RAS system, like where the aldosterone, like where it shuts the kidneys down, so it runs blood to everything?
Yes, yeah, kidneys, you can live without kidneys and the body like naturally knows that, and so it doesn't perfuse the kidneys, right? Which is why we have a lot of acute kidney injury because of this. So, do you see this modeling? You see how this looks kind of like webby? That's what happens, okay? Your blood is going up. This is what's left over in the capillaries. Okay, this is called modeling. It's a bad sign. Anybody who's ever worked hospice or anyone who's had a terminal patient, they do this near the end. Okay, so this part that glows, that's where they're shunting the blood, not anywhere else. So just really think about that. Okay, when you get to the fourth stage, that's it. It doesn't matter what you're trying to do, but once you can't like pour water onto a brick, right? It's already a dead organ and dead tissue. It doesn't matter if you're doing different types of things to try to get it reversed. Okay, so that's a bad day. What we were going to talk about then is the different types of shock and what it looks like and what indicators you'll see where you're like, oh, hey, that looks very different. So we're going to talk about our blood loss. We're going to talk about our vital signs. We're going to talk about our mental state, because our first sign of poor perfusion can very often be confusion, right? We don't have to wait till your legs look like that and you're modeled to know that there's something going on. So we're going to talk about each body system, okay? So in the early stages, I tried to do it as similarly as I could. You're not going to see any changes. This is initial, this is early. You're really not going to see much. Maybe a slight increase in heart rate, maybe a slight increase. Maybe a little tachycardic, right? 120. Is 120 that tachycardic? You have a test on it tomorrow. Is 120 that tachycardic? Not really, right? You get that with a fever, right? Your pulse might be starting to become more thready, right? But as these do not get fixed, if we don't recognize their tachycardic, if we don't recognize the change in their pulse points, right? Then we're going to end up with this problem, which is the low MAP. The low mean arterial pressure, you're going to have your blood pressure tank. You're going to have a decrease in cardiac output. When you think of shock and you picture that pump and the heart and the vessels and organs, right? As the tank starts to empty, the heart is going to pump faster, right? Because it doesn't have as much. It thinks, oh, I've got to go a little faster because I have this much to go around. So I got to get it there faster. Okay, so think low BP, high heart rate. That's what we're going to see in shock. That's the hallmark there. Low BP, high heart rate. Okay, and when that heart rate drops, then you're really not good. Okay, with progressive, okay, we're also going to have a risk of cardiac dysrhythmias because remember we talked about with the progressive shock, you've got your acidosis, you've got your hypoxia, you've got your tissue perfusion that's completely minimal, you've got your MAP below 60. So when that happens, the heart is going to not get enough blood. We just spent 3 weeks talking about the heart, and when the heart doesn't get blood, in fact, it impacts its contractility, it impacts its conduction system. So you can easily go into cardiac dysrhythmias, as well as all the things that we talked about with congestive heart failure and MI, all of those changes to the EKG, all those changes to the contractility and fluid. Okay, so just like reference what we did the past few weeks. When we're looking at the respiratory system, okay, we're going to breathe faster first. Because again, we're going to try to get more oxygen, get it moving, but our gas exchange is impaired. So if we don't get the oxygen delivered to the tissue, that means we also can't pull the carbon dioxide off of the cells. So because oxygen doesn't get there, carbon dioxide stays, and then we end up with more acidosis. Okay, so what that can lead to is what we'll talk about in a couple of weeks, which is acute respiratory distress syndrome, which is a whole nother cascade of damage that happens to the lungs and happens very quickly. Okay, so again, we know why we try to compensate, but after a while, once that respiratory acidosis gets too high, it's a cliff, right? We compensate until we just can't anymore. When we look at the liver, right, this has an impact as well. So when we are under a little bit of stress and the heart rate's going up a little bit, we're starting to breathe a little faster. The liver is gonna make more glucose because the body needs more energy to kind of go through those first stages of shock, right? To get everything where it needs to be, responding to stress. As we progress though, and blood supply to the liver drops, then we make less glucose. And then we can't get rid of the extra acid in the body. And again, we have another problem. We have more metabolic acidosis, and then we have hypoglycemia on top of it. Okay? We don't think about our gut very often, but think about how much vasculature and how much blood supply goes to our gut. So in the beginning, it'll just kind of decrease our motility. Okay, but as it continues on, we end up with being paralyzed. We don't have blood to push the muscle, right? To push everything through. We also have a risk of hemorrhage, right? And of necrosis. And we know that that can be another sign. Okay. Our neurologic system is sometimes the easiest one to see if something is not right. Okay, it can be something about being kind of sluggish, to being very anxious, to being very restless, right? They just don't feel like themselves. They might be a little confused. But that will eventually go to lethargy, right? And obtuseness and not responding. And then that eventually will lead to coma. So if your patient was fine when you went in and checked on them, and then you come in later, 2 hours later, and they are really difficult to wake up, that's a sign. That's telling you something happened with them. And we got to look a little bit deeper. Okay. Our kidneys, we talked about that already. The kidneys, the body does not think is a mandatory need to perfuse. So as the perfusion goes down and our filtration rate goes down, we're going to make less urine to the point where we're not going to make any, right? Anuric is no urine at all. And then we have our kidney injury or kidney failure. Again, how many people have you heard of that were in the ICU for one thing, but now all of a sudden they're in renal failure and they have to get dialysis, right? It's because the body's not taking care of the kidneys. On our skin, we're going to notice pale, right? And regardless of the skin pigmentation, we look at the inside of the cheek, that buccal mucosa. Early on, they're going to be kind of cool and moist on the skin. And after that, because everything is third spacing, we're going to have swelling. Okay, but that's a late sign. We're also going to have our skin, for the most part, an asterisk around there because there is one difference. We're going to have skin progressively get less warm and they're going to become more thirsty. Yes.
The swelling is from the blood vessel or the blood cells expanding.
Yes. So once the cells suck in enough water, right, the water follows the salt and eventually they explode. So there's nothing to hold inside the vessels. And so the water leaks out and you have third spacing. Does that make sense? Okay. So early signs of shock, change in level of consciousness. Late signs of shock, right? That's where we get our big changes that we think of. Our low blood pressure, high heart rate, and significant mental status changes. So know this slide. Okay. We went faster than I thought. Do you need a break? All right. So we're going to go back to this example where we've got the tank, the pump, and we've got the vessels. All right. We're going to talk about individual types of shock now. So what are the different ways those can get disrupted? We've got our cardiogenic shock. So think of everything that we talked about with congestive heart failure, with myocardial infarction, with acute coronary syndrome, all the different things that we just talked about. Pulmonary edema, cardiogenic shock. Obstructive shock is very similar to cardiogenic to the point where we lump them together. It is an ineffective pump. One is a heart issue. One is an obstruction issue, right? So there you got your pulmonary embolism. Okay, same concept. It just depends if it originates in the heart or originates somewhere else and affects the heart. Then we have hypovolemic. This is our most common one. You're going to see this one so often, right? I can't even tell you how much, especially when we get into peds. Hypovolemic, right? We have something, we don't have enough volume. And then the last one is distributive. And that means that the blood is distributed in other parts in the body and it's not making it back to the tank, so it can be pumped again. So these are the four, but really we're gonna talk about 3 mechanisms of action. Okay? In your book, they have a really good figure of shock as far as it kind of breaks it down and puts it in a nice chart format if you're somebody who likes that. Okay, good information in there. So hypovolemic is the one we're gonna talk about first because it's the most common, and that is where the tank is not full, right? So we have not enough preload, there's not enough left. Okay, so our cardiac output's low, our blood pressure's low, heart rate needs to go up, and our stroke volume can go up. Okay, so nothing wrong with the tank, nothing wrong with the pump, nothing wrong with the organs and the vessels. It's all a matter of there's something interrupting or leaking that our tank is not full. Okay, so you can see this with other types of shock because if other things are happening, eventually the tank is going to empty. Does that make sense? When I say tank, you know what I'm talking about? Okay, so if your volume is down 15 to 30%, you're already headed into hypovolemic shock. Okay, so we know that if there's less blood volume, our blood pressure is going to decrease, right? And so what does the heart do to compensate? Heart rate speeds up. Yep, exactly. So we might see this in trauma. If you have a hemorrhage, right? If you have esophageal varices, right? You're bleeding. If you have surgery, right? And you nick something and it's bleeding. Or if you have some type of an inability to clot, that can also cause bleeding. So think of your hemophiliacs, okay? And then we have loss of fluid, intravascular fluid. Think of burns, right? That's your whole outer layer, right? That holds all those fluids in. If that is not intact, if we have some type of dehydration, if we're nausea, vomiting, diarrhea, if we take too many diuretics, right? If we have some type of condition like liver failure, where all your fluid's gonna pull right into your belly or in your lungs, okay? So different ways where you're losing some type of fluid or volume is gonna lead to this. So I made a chart for every one of these to show you the difference. So what I invite you to do is to look at this chart, and I want you to, as you compare these when you're studying, a lot of them are gonna look the same, but I want you to focus on the differences, right? So for this one, it says rapid thready pulse, okay? Marked thirst, acidosis, delayed cap refill. So keep an eye on these, and then when you are studying, go back and compare and contrast and find the differences. I'm not gonna ask you like, what's normal on all of these? I will ask you what is unique. Obviously yellow, not as bad, red, very bad. Okay. Any questions on hypovolemic shock? Okay, so here's the thing with hypovolemic shock though. What is the fix for it? How do we make it better? We give them fluids. What do we have to be careful about if we give fluids quickly? Fluid overload. What did we just talk about last week? Where does the fluid sometimes go? In your lungs, and you have flash pulmonary edema, right? So it's a delicate balance. I, to this day, wake up sometimes and think about a patient that I had. I had an Amish kid who came in, and my kid, he was probably, what, 18? He was an undiagnosed diabetic. We diagnosed him like that day. Okay. His pH was 6.9 when he got to us. So we're talking about acidosis, really, really severely acidotic. Okay. His blood pressure was about 60. His heart rate was in the 50s because we had passed the tachycardia and now we were on the downslope where he wasn't compensating at all, much at all. He was mottled. He was so sunken in and so dry and cracked because he had been in DKA for who knows how long, right? His blood sugar, I think, was like 1500. It was ridiculous. So we needed to give him fluids, but we also know if we give him too many fluids, then he is going to go into flash edema, right? So we ended up giving him like 3 or 4 liters because his circulatory volume was so bad. that we needed to get it back up. So after leader number 4, he finally started like responding. He finally started like opening his eyes and asking questions, and we shipped him because obviously I didn't work at a level 1 trauma. But I worry, like, did they know? Did they really listen when we told them he just got 4 liters of fluid? Like, did they intubate him so that they were ready for it? Like, I still worry about that because sometimes the cure also is a curse, right? So if we gave him that fluid, he wasn't gonna live without it, right? He didn't even have enough volume to even use a vasoconstrictor because you can't like squeeze a dry sponge, right? There has to be something in there. So we call that priming the pump, where you have to give them some fluid so that they have something to circulate, but then you also don't want to give too much. So it's a delicate balance when you come to these. Okay, cardiogenic or obstructive shock, same mechanism, just depends on what's causing it. Tank is fine, plenty of blood volume, no problem there, right? Organs are fine, no problem there. The problem is in the pump itself. Right, so this is the person that had the MI. This is the person that has acute congestive heart failure, right? This is a person who has the pulmonary embolism, where it's interfering with the lungs and the perfusion to the heart, okay? We see this due to any type of cardiac factor and based on how bad it is, right? A non-STEMI versus a LAD Widowmaker 100% inclusion, right? That's gonna tell you how bad this shock and how quickly it's gonna progress based on that, okay? The most common form of cardiogenic shock comes from an MI, okay? That is the most common, but there's plenty of others. There's another 2 in here that we haven't talked about yet. We will eventually, and that is valve problems and aortic stenosis. Okay, these are other things that can go wrong within the heart. If the aorta, which is that large branch off of that left ventricle, right, that feeds the body, if there is plaque, atherosclerosis, or hardening of that artery, that will impact what we do and the ability of the heart to pump. And also valves, right? So if you have a valve that's not closing like it should, or the structure is bad, that can also cause the heart not to pump well. Okay, so more often you're gonna see that blue tinge. You're gonna see the cyanosis because it is a matter of the pumping action. So the lungs are not perfused and the circulation is impacted. And then because we're not pumping, right? The blood's gonna stay in those capillaries, it's gonna stay in the periphery longer, right? So because of that, it can pull out the carbon dioxide, but they don't necessarily put the oxygen in because it's not fresh oxygen. So we do have acidosis, but we sometimes end up with more damage. Okay, that's why they get cyanotic. Looking at this, I did not do a early, late, middle, late, okay? But with this, we're also gonna see some venous distension, okay? We're gonna see everything we think of with our CHF patients, our pulmonary edema. We're looking at starting to get the moist skin, peripheral edema. And then we've got some factors here that we just talked about. That central venous pressure, remember that catheter floats and it either stays in the subclavian or in that right atrium. Or we've got that pulmonary artery wedge pressure where we go all the way through and we're into the lungs. So some of that advanced things that we did with the heart, we're also going to use to monitor for the cardiogenic shock. Okay, so those are the things that you would obviously highlight as differences. Whereas obstructive shock is due to the non-cardiac factor. Same basic idea where we could have a pneumothorax, right? A collapsed lung, or we have tamponade where the heart is kind of getting choked, right? There's fluid around the edge of the heart so it can't beat, the PE or the aortic stenosis. Okay, so something not in the heart, but it affects the mechanism of the heart. Make sense?
You're talking about fluid in the pericardium?
Yes.
Okay.
Yep, that's a tamponade. And the last one we have is distributive shock. Okay, so we have good blood volume. Our pump looks pretty good, but for whatever reason, we can't get the circulation from the organs back to the tank. And you can see that thicker, bolder red line, and that just demonstrates that that's where the blood is really stuck. Okay, it's distributed everywhere and not where it's supposed to be, and that's where we end up with that distributive shock. Okay. The blood volume in this does not change. We're not losing it, we're not leaking it out, and we're not gushing with a hemorrhage. It just can't get back to where it needs to be. And that's where we get the signs of the hypovolemia. Yes,
Would this be like, if we gave somebody nitro and they'd already had a vasodilator and you're just opening everything up?
it could be, yeah, that could be. And we're gonna talk about the difference, the septic, neurogenic, and anaphylactic fall underneath there, but yeah, it's the same type of thing. Yeah, blood's still there, just not where it's supposed to be. Okay. So when this happens, we might get skin that's not cold and clammy. We might get skin that's hot or flushed or warm to the touch. We think of shock, we think of cold and clammy, but in the beginning stages of distributive shock, because the blood is stuck in the periphery, right, and it's there, it's not a matter of not getting there, it just can't get back. Sometimes they appear warm and dry. So again, if it doesn't look like what you typically think shock is, you might miss it. Okay, so if you have a patient that has a fever and their skin is warm and flushed, you might not automatically think, oh, I might think sepsis, right? Until it's too late. So just keep that in mind. So septic shock. Anybody work in a hospital where they have SIRS alert or sepsis alerts? You've seen those at Ohio Health where it pops up, where they've got that little sepsis thing. Here's why. Sepsis is very commonly missed, and in the elderly, it's one of the #1 causes of mortality. Right? Why do older people have higher rates of sepsis? What type of infection do they get? UTIs, a lot of times. Dehydration, indwelling catheters, those type of things. So we now, as a healthcare community, have to be on alert, right? We have our SIRS screen, we have our sepsis alerts, and here's why. Because it can be the result of bacteria that sometimes in a healthy younger person, it might not cause a problem. But in our other population, and let's be honest, what percentage of our hospital inpatients are older? We got those baby boomers, there's a lot of them, right? So with this, we have the septic shock, we have the sepsis with persistent hypotension. Okay. The only way you keep your venous arterial pressure above 65 is if you have some type of intervention, like a vasopressor, a constrictor, to keep your vessels going. And we talk about serum lactate greater than 2. What does lactate, lactic acid, what does that show us? Cell death, muscle death, right? When we have patients that have a lactic over 2, it can be an indicator. Okay, it might not be the only indicator. And actually, in your module, whatever organization does all of the evidence-based practice, they've actually found that lactate used to be the gold standard, and now there's so many other things that we know go with sepsis. It's still important, it's still part of it, but we have to look at other things too, right? So look at that lactate, but also don't get fixated if the lactate comes back at 1.7, right? But they've got 15 other signs of shock. We're not gonna wait, oh, well, their lactate's not 2. When it's 2, then we'll worry about it, right? We see the SIRS alert, and our computer systems now trigger it for us. If there's metrics, if their fever is up, if their temperature is too low, if they have elevated vital signs, if their lab works, if their white count is too high or too low, okay? Or if our carbon dioxide is dropping. So when you look at this SIRS, I could probably think of 50 reasons why my patient would have those indicators, right? Maybe their white count's low because they are having chemo. Maybe their heart rate's high because they're in pain. Maybe they got a fever because, you know, they've got a cold. I don't know. But that is not our indicator necessarily that they're headed towards septic shock, but we definitely want to keep a look at it. Sometimes we get pop-up blindness on our computers. Like every time you log in, there's these pop-ups and you just kind of ignore it. Try not to, because that might be the first sign that something else is coming. Once we get a SIRS, right? And we've got 2 of these indicators, and maybe we think we've got an infection. Now we call it classified as sepsis. Then, once we get to the point where we're starting to see some changes in our vital signs, our blood pressure, those type of things, then we're headed into that septic shock. Okay, there's a lot of stages we can intervene before we actually hit the shock. A lot of times it gets missed. That's the part that's hard. Okay, so definitely keep an eye on that. How are you at risk? Anytime you have a portal of entry, anytime you have surgery, anytime you have any type of tube implanted, anytime you're immunocompromised, all of these things put you at risk for sepsis. And again, our older adults, we see UTIs. What's the number one sign that an older person has a UTI? Confusion? Is that what you said? What else did you say? Fever? Before you even get to any changes in anything. Any older person who comes in with mental status change, always think UTI every day, all day. Think of that first. Okay, before they even spike a fever, that'll be your first thought. Okay, so when you hit septic shock, you've already gone past the SIRS and the sepsis, and now we're in severe sepsis. Now we're actually in the shock part of it. This is distributive shock. So do we have any change in our blood volume? No. Do we have any problem with our heart pumping? No. Why are we in distributive shock when we're in sepsis?
Because the blood is going to the source of infection.
The blood is out in the periphery, right? It's all in our vessels. It's in our arms and our legs and not in our heart and our lungs, right? Does that make sense? Okay, so when all of this is happening, okay, not only do we have low volume, right? And we know everything's out in the periphery, but we are also at risk for something called disseminated intravascular coagulation. Have you heard this term before? DIC, have you heard that before? Do you know what sometimes people refer to DIC is? Death is coming, okay? What that means is that all of your clotting factors are activated, but they're all activated in one area, which leaves the rest of your blood unable to clot. And you will bleed profusely from everywhere, okay? And we're not talking like, oh, we have like a little bleeding coming here from the nostril. We're talking like your eyes, your ears, your nose, your mouth, anywhere that there's an opening is massive bleeding, okay? And anywhere that you have had an injection, an IV start, any type of line taken in or put out, any type of bruise you have, any damage to the body will automatically become a huge source of bleeding, okay? So you're bleeding, you're clotting at the same time if you have this. Yes?
So the place that it would clot, is that like the source of the infection?
Sorry, I got distracted by whatever was happening back there.
So the place that it would be clotting, would that be like the source of the infection? Like if they have a UTI, like urethral clotting?
No, it's where they will activate in random spots. Like it actually just makes like a big clot in random spots. And then they're all clumped in one area. Does that make sense?
Yeah.
That's not at the source of anything. It's just intravascular, somewhere in your system.
And it's just because the same way that AFib would cause a clot in your heart because the blood's not able to move, this is just happening in the periphery.
It's less to do with it not being able to move and more to do with the inflammatory response that's caused by the sepsis.
So where all the clotting goes to one area and there's nothing to go anywhere else.
Right, so like in my water bottle, right, all the clotting factors would be in this area and then the rest would just be totally liquid and unable to do anything. Okay,
Is
yes,
there a test, like a lab value they test to see if that's the case, or it's just all symptom related?
a lot of it is symptom related because it's not that the clotting is not happening, it's just not happening at the right places. Does that make sense? And sometimes it's not like a huge clot, it's like, we're talking micro clots all the way through. Does that make sense? So the clotting factors are there, it's doing what it's supposed to do. It's just a matter of not being where it should be, right? That makes sense? We'll talk about this more in 2030 when you talk about, DIC is a pretty uncommon complication with childbirth. If you have like postpartum hemorrhage, they could go into DIC. Okay, I went into DIC when I had my kids. It was no fun. I'll have to tell you that story. When you get to 2030, I'll tell you my birth story. It was crazy. Okay, so when we talk about sepsis, okay, all of these things, including sometimes you'll get a septic rash. Okay, so all of the normal things, they might have chills, they might be hot. They might have a foul odor to their breath, right? They might have pain, random places. Okay, or they might develop a rash. And sometimes we get the rash, it depends on what the bacteria is that's causing it. Okay. Does this make sense?
That's basically the signs and symptoms.
Signs and symptoms of septic shock. Yep. Questions on septic shock? Who has not seen a patient in sepsis? It's pretty common, right? If you haven't, you will soon. And a lot of times when you get patients on the floor, it'll be, they were admitted, rule out sepsis, right? They know they have a UTI or they know they have whatever going on and they're trying to rule it out and try to get it under control before it progresses to shock. Okay. Neurogenic shock. Did you talk about spinal cord injuries over the summer with Katie? Okay, so when we're talking about this, so you know what the autonomic response is, right? You know what the autonomic nervous system does? So when this is triggered, right, we have a decreased vascular tone when this nervous system's response is activated, and that causes all of the vessels to dilate. Right? And so that makes sense. This is coming from the brain. It is a response where everything opens up. So we're not talking, there's no pathogen, there's no immune response really. This is all coming from your autonomic nervous system. Okay, so if all of a sudden you have the same amount of volume, but you have double the space, instead of filling the vessel, it's only going to be in the bottom part. So that makes sense why we would have decreased pressure because there's not enough in it. Okay, so spinal cord injury, head injury, traumatic brain injury, some type of central nervous system depressant, so drug related. Sometimes anesthesia can cause it. Sometimes it's a severe pain response or it's exposure related, right? If you've been exposed to heat for too long. So all of these things can trigger your autonomic nervous system, okay? And it can cause your vessels to expand. So if you have a patient that has some level of paralysis, a lot of times you'll see like kind of reclined wheelchairs, or they have the ability to recline because they don't have that tone, right? They don't have the ability. So I don't say a lot of times, but I've seen many times where people are in wheelchairs, right? They don't have any muscle tone in their lower limbs. And so it's not constricting like it should. They get very lightheaded, they get very dizzy. So they have to be able to lay back to kind of even things back out, right? That's that autonomic response. Okay, so with this, we have kind of the same type of things, okay? But again, we are looking at a distributive shock. So we are eventually going to get pale and cool, all right? But because of the way that the body is responding, the nervous system's driving it, they may still be warm at first, okay? They might have a slow bounding pulse, but then it goes to tachycardia. It depends on how that autonomic nervous system regulates it. Okay. And we're gonna be done really early today, I think. Yeah, I know, try not to cry. So the last one is anaphylactic shock. Who has seen anaphylaxis in a real patient? Okay, Corey, what did it look like? Horrible. Could you elaborate on that a little bit?
It looked like they were kind of choking and trying to fight for breath and like.
Anybody ever been in anaphylactic shock? You have been? What are you allergic to?
A bunch of things, but the one that really goes me in is rodents, guinea pigs, rats, stuff like that.
Okay. Exposure to their dander?
Yeah.
Yeah. That's not what I commonly hear, but I will keep guinea pigs away from you, I promise. All right, so I actually do a little bit of deep dive onto anaphylaxis because I know what happens and I know what it looks like and I've treated it a bunch, but I couldn't really put my finger on why it was happening, which I kind of wanted to know. So I know it's an immune response. I know the things that trigger it. And you don't have an allergic reaction the first time you're exposed to something. Did you know that? Your body has to build up some antigens, so it responds, okay? Perfect. What I didn't know, I know that we have histamine reaction, right? You take your Benadryl and you take your Pepcid, But I didn't realize that it was because of the histamine response actually triggers the smooth muscle in your larynx and your bronchioles and your abdomen. And so just that smooth muscle is contracted, which is where you have your throat, your lungs, and you get horrible abdominal cramping with it. So I learned that. Thought I'd pass that on. So you also have a smooth muscle in your bladder. And so sometimes they are incontinent as well. So those are the areas that are going to be triggered by that smooth muscle, which makes sense because that's where you breathe, right? So we know it can progress extremely rapidly, like within 20 minutes of eating something or being exposed to something, you can be in anaphylaxis, like that fast. Okay, we know this. I think everyone has seen an EpiPen at some point, right? Okay, but it also will cause eventually, if we do not, so we always think of the breathing, right? We always think of the air up here because the airway, but it also can affect that vasodilation. Everything can pool in the vessels, and then the blood pressure drops. So anaphylaxis itself can then progress to anaphylactic shock, which is our distributive shock. Does that make sense? I had a patient one time that had an anaphylactic reaction. This is pre-computer charting. Okay, so keep that in mind. That's how old I am. But the doctor wrote for Epi, right? This is before EpiPens were super common. You got your little vial, and you drew it up and you mixed it up and you gave the 0.3 sub-Q. Well, for whatever reason, the nurse who was helping didn't see the sub-Q and just grabbed an AMPA Epi out of the drawer and went ahead and pushed it. So please know it is the same medication that we use during a code, right? To improve our heart rate and our contractility and all that. But it's a very, very small amount. It's a more concentrated amount, but it's very small, like 0.3 mLs is what you're giving. Whereas in a code situation, it's an amp, okay, which is that whole box. So that patient had a quick MI because of it. It was bad, yeah. So just make sure you understand that just because a medication is given for one thing, it may not be the same concentration or amount for the next. So just keep that in mind. Okay. With this, we're obviously gonna have a lot of respiratory symptoms, right? We're gonna have the dyspnea, we're gonna have our wheezes, okay? We're gonna have swelling, edema, lips, tongue, throat, okay? All these things in here. They also may have hives and itching, and that may come before we have the respiratory symptoms, depending on how fast they progress, okay? Also, if someone has a history of an allergy and they get hives, does that mean they're never gonna progress to swelling in their throat and their tongue? No. Please remember that if someone says they have an allergy, we go through that med rec. What are your allergies? What are you allergic to? What are your symptoms? If they say hives, right? It may have been hives one time, but the next time it might be a true anaphylactic reaction, right? Where they end up with the breathing and the shock that progresses. Okay, let's take a break. We went through how shock, do you understand? Let me put it this way. Do you understand how shock happens? And you can understand the 3 different mechanisms of how it occurs. Yes? Okay, good. Now we can take a break. All right, so if I told you that your patient has a UTI, what type of shock is that?
I'm sorry?
If I said your patient had a UTI, right, and they were progressing to sepsis, what type of shock is it? Septic shock, which is distributed.
Can't-
Jay's having a,
Can't
that's
say
a stroke. Okay. I was, okay, I know that, yeah, I know online's not real all the time, but there was a girl who said that during the presidential debate with Biden and Trump, that her dad was like stuttering and stumbling around and they thought he was making fun of Biden. He was actually having a stroke. They got him help, but they waited a good half hour. They're like, man, he's really committed to this bit. And then for real. Right. if I told you that your person is experiencing an MI, what type of shock would you be concerned about? Cardiogenic. If I said that your person has a pulmonary embolism, what would you be concerned about? Obstructive, affects the heart, affects the pump, but it's outside the heart, right? If I told you that somebody had nausea, vomiting, diarrhea for a week, hypovolemic, okay? So I do want you to know this stuff for the test. I do want you to memorize those things, right? Of what they look like. But what I'm more important in is when you are taking care of your patient on the floor, you're looking at your patient and you're looking at what they are there for. I want you to think one step ahead on where could this be going, right? If my patient has this, what could they end up doing? Right? If the vital signs change and the heart rate's elevated and the blood pressure is low, I want your spidey sense to tingle and be like, ooh, I gotta keep an eye on this, right? Maybe they're orthostatic, right? Maybe it's an actual drop in mean arterial pressure, okay? When we look at this stuff and we're talking about how do you measure mean arterial pressure, I don't want you to take the hemodynamics that we talked about from the first exam and like, boop, and throw it out and then focus on the new stuff. I want you to bring it with you so that when I say your pulmonary artery wedge pressure, you're like, oh wait, that's the catheter with the little balloon that gets stuck in the lung, right? Oh yeah, I see why we need it for this. So bring it with you, okay? Everything is threaded together. We try to build it in a way where you're gonna use it all. I don't want you to lose it, okay? And then when you get to peds, we're gonna bring all this stuff with us. We're just gonna talk about different size bodies and different like mechanisms in the body system. So keep going, okay? I know this is a marathon sprint pace, right? It's everything all at once, okay? So we're gonna look at diagnostics and what that means. Okay, so what type of things are we gonna look at? The first couple slides, all right, under each type of shock that we went over has what their vital signs will look like, what their respiratory status is gonna look like, what their metastatus is gonna look like. Here is what we're gonna look like from a testing perspective, okay? We know that our main problem with shock is lack of oxygenation to the tissues. So we are gonna do an ABG all day, every day, okay? We know that if we cannot get oxygen in tissues, we also can't get carbon dioxide out of tissues. We know that the cells, when they get too much into them, too much fluid, they explode. We have all these reasons why the body is going to be acidotic. Okay, what is a normal pH value? 7.35 to 7.45. So in an acidotic person, where's that pH gonna go? It's gonna head towards 7, and then it's gonna keep going. Very acidotic. We're gonna have low oxygen and high CO2, and that makes sense why, right? If we're not circulating, we're not delivering things, we're not pulling stuff back, right? Oxygen's not getting to the lungs, it's not getting out to the body. We have lactic acid, right? And that makes sense. Those cells, they're gonna break apart. We're gonna have all sorts of intracellular things in the extracellular space. And then we end up with a high lactic acid. What is the indicator for sepsis? 2 is what we look at, right? Bonus points. What color tube do you draw a lactic acid? You can't answer. What color tube do we color lactic acid?
Is it purple?
Purple.
Red, green.
Gray. Lactic acid is gray, right? And I have to retrain myself because we are always learning. Nursing is always learning and adapting to evidence-based practice. I would have told you, bet my next paycheck, you put a tourniquet on, you find the vein, you take the tourniquet off, you draw without a tourniquet, you put it on ice and you send it to the lab. Ohio Health doesn't do that anymore, right? Evidence-based practice says you don't have to put a lactic tube on ice. So if I say lactic on ice, just mean, no, I mean a gray top, okay? But those are the type of things. Could you change your machine?
Certain machines require it to be on ice and certain don't. So depending on which hospital you're in, It might still. be-
I will always probably put it on ice and I'll probably ruin it at Ohio Health, but. Right, and the reason why is that if you are pulling out lactic acid and you're looking for cell death, the last thing you wanna do is put on a tight tourniquet to squeeze this muscle. And then draw it and then let it sit around for a while, like you wanna get it a fresh, undisturbed sample on ice is what we want. But if you have new equipment, we'll do that too. Okay, our electrolytes, remember, where is glucose produced? We talked about today. In your liver, right? So initially, the glucose production is going to increase. Why?
Trying to give you energy to beat back what's going on.
Right, we gotta combat whatever stress is happening. But eventually, as the perfusion of liver happens, if it is not perfused, we have less glucose. Right? We have less sodium because water follows salt. So if the cells explode and the water comes out of the cells, the salt's gonna follow right behind. Right? So we're gonna have low salt, but also all the potassium is gonna be high. So acidotic, hyperkalemic, okay, hypoglycemic. And then we're gonna look at the kidney labs, right? All of our renal labs. What happens when blood doesn't go to kidneys? They die, right? So we're gonna see our BUN, our creatinine, our osmolality, our specific gravity, everything's gonna be super elevated, right? That's our indicator of kidney injury and kidney failure. This makes sense. Okay, do you understand the why behind these values are what they are? That's gonna really help you on test questions and when you're caring for your patients, right? We're looking at shock. We know we have different kinds. There are specific labs that go with different types of shock, right? So septic, this is caused by what? An infection, right? So what are we gonna draw? Blood cultures. What are we gonna do before we draw blood cultures? We're not gonna give our antibiotics first, right? So if we wanna know what's truly going on in the body and I want to seriously know what's happening, I need to make sure I get a really good picture. If I've already given that Levaquin, it's not gonna give me an accurate picture of what's happening, right? So blood cultures first, then you can do antibiotics if you want to. Draw your white count and draw your coagulation labs, your PTINR and your APTT, right? For cardiogenic shock, it makes sense. We just spent 3 weeks talking about what are our cardiac enzymes. Troponin, your CK, your CKMB, your myoglobin. You said D-dimer. That's more for PE, but if it's for obstructive shock, yeah, perfect. You guys know that D-dimer, you draw that for PE? No? Okay, we're talking about that next week. And then our hypovolemic shock. This is where our tank is empty. Okay, we're very low. So if it is a result of bleeding, what do we expect our hemoglobin and our hematocrit to be? Low, right? If they are hypovolemic because they've lost other fluid, what are our hemoglobin and hematocrit gonna do? They're gonna be concentrated because they've lost all that other blood, all the other fluids, so they're gonna be all concentrated together. So if we look at it and the hemoglobin and hematocrit are low, but we don't see external signs of bleeding, right? What are we gonna think? Some type of internal bleeding. Yep. So obviously, if it's a gunshot wound, right, you're gonna see where the bleeding is coming from. But if it's low and you don't see it, then we have to do some investigation.
So the edematous person, would that be high due to the birth spacing?
It can be. So she said in a edematous person, could the H&H be concentrated because their fluid is third spacing? Yes. Yeah. Okay. Testing and monitoring, right? What is this picture of? What do we call that? You know? It's Trendelenburg or the shock position. And what that does is we know that in shock, right, especially in distributive shock, we've got fluid in the leg, we've got our blood volume in our legs. So by lifting them up, it naturally has gravity, help to feed the lung, the heart, and the brain. So if you have somebody who you suspect is going into shock, right? And you are not in a hospital setting, you could lift their extremities above their head. or above their heart. Or if you're in the hospital, you tip that bed back, right? Trendelenburg, kind of stand them on their head. Okay. But that's just a little aside. We're gonna look at our heart function. We're gonna look at our echocardiogram. We're gonna look at our ECG. We're gonna see if there's any dysrhythmias. Okay, we're gonna get a CAT scan and see what's going on inside. We're gonna chest X-ray. We're gonna use our hemodynamics. We're gonna put in an arterial line to monitor that map, right? That mean arterial pressure. And we're gonna use that pulmonary artery catheter. We're gonna check it, see what's happening on the heart. Okay, so it all kind of ties together. One of the things that we do is we can use an intra-aortic balloon pump. Anybody seen one of these before? Okay, these are really awesome. And there's lots of different ways. I'm gonna show you a video on the two of them so that you can understand the difference. One is very new. They're just starting to implement it in Ashland. I don't know if they use it at Ohio Health, and one is kind of like the gold standard. So what this is just like when you're getting a cardiac cath, right? They're gonna float this in, right? And it's a balloon. It literally looks like the little balloon like you make balloon animals out of. That's what it looks like attached to the catheter. So when they float it up in, it actually deflates when the heart pumps out. And then it inflates during diastole. And what that does is that pushes blood back into the heart muscle itself. And it helps to make sure that the heart muscle is perfused. Okay, so there's two different ways you can do that. This is your standard intra-aortic balloon pump. There's a next generation of that has to, it's called an Impella pump.
Is this like a temporary?
Yes, it is temporary. Yeah, it is 100% temporary. You do not want to have that for a long time, because again, that would probably cause way more problems, right?
And it's just to help perfuse.
Yes. There it is. Sorry, got 400 screens I gotta do here. So there you have the intra-aortic balloon pump, and then this one's called an Impella pump, which is a much, much smaller version.
The Impella is the world's smallest heart pump. The cardiologist places the Impella heart pump into position using standard cardiac catheterization techniques, inserting the catheter into the leg artery and guiding it into the heart. Once in place, the Impella pump is turned on, providing support to the heart while monitoring the pumping activity. The Impella pump mimics the natural pathway of blood flow from the heart to the ascending aorta, increasing blood pressure while unloading the heart and providing more blood supply to vital organs such as the brain and kidneys. A protected PCI procedure with Impella could lead to less days in the hospital, fewer repeat procedures, and an improved quality of life for the patient.
So you can see it's just like this little teeny tiny vacuum where it actually sucks it up and then like disperses it where it needs to be. Okay, so that is incredibly small and it works really well. Whereas the other one here, now keep in mind it's a YouTube short, but it's the best I could do.
Anyone guess what this medical device is? If you said intra-aortic balloon pump, then you are correct. Intra-aortic balloon pumps are a common tool that cardiologists use to treat cardiogenic shock. In cardiogenic shock, the heart is not able to pump enough oxygen to meet the demands of the body. The two main mechanisms that this helps treat cardiogenic shock is by decreasing myocardial oxygen demand, by decreasing afterload, and improving coronary blood flow. The balloon inflates during diastole and deflates during systole. When it inflates during diastole, it pushes blood back to the heart and increases coronary blood flow. You can remember this because most of coronary blood flow occurs during diastole. This improves the amount of blood flow that the coronaries get. The second mechanism in which this helps in cardiogenic shock is by decreasing afterload, or the pressure that the heart has to pump against. When it deflates during systole, it causes a suction effect and improves the cardiac output. Contraindication.
Okay, you thought I talked fast, Emily. So you can see what that does, how it when it inflates, it pushes the blood backstream, right, to feed the heart. And then when it deflates, it kind of helps pull the blood out, which gives kind of a little head start so the heart doesn't have to pump as hard. So if you have patients that, I told you about my mother-in-law last week who was at the hospital and they ended up overloading her on fluid and she went into pulmonary edema. Did I tell you about this last week? What happened was because they overloaded her on that, they ended up putting her on the balloon pump for a while so that her heart could actually rest and not end up with having to work quite as hard.
So did she have Impella or intra?
She did the intra-aortic, okay? And you can actually do more than one of the Impella also. So if you need both, so they can actually put one in the right ventricle and one in the left ventricle, so it can actually help both sides of the heart, depending. So those are some of the newer technology. For kind of the gold standard though, what kind of the tried and true method for people that have comorbidities, they've used this one. Yeah.
So she said it would be temporary, like how long is temporary, like a couple hours or a couple days?
Like 24 hours to 72 hours, I would say. It's all hospital protocol, but I mean, it's pretty invasive, so you have a huge risk of infection. But
But does it measure how well it's pumping, like? Is it to give it a break?
it is, because when this is inflated, if you have heart, so when we talked about MIs, right, that heart muscle can get stunned, meaning it's not dead necessarily. It's not completely irreversible, but it definitely is not functioning 100%. So what this does then is it pushes the blood back and it makes sure that that muscle gets a little extra burst of oxygen so they can kind of remodel itself and get a little better. And then also when it deflates, it helps to pull, so the heart doesn't have to squeeze as hard. So what that does is kind of gives it a chance to just beat kind of slowly, and not have to do as much contraction and get itself reperfused. A lot of times they'll do this before open heart surgery so that the heart muscle's as healthy as it can be. Because when you do that anastomosis and you reconnect those vessels, then it has a better chance of adhering. When my husband was in the hospital, his non-STEMI had happened a couple days before. And so his heart muscle was so sick and so beating so poorly. They put him on heparin and they did the balloon pump and they did it for a couple days so that the heart muscle was as healthy as it could be so that the surgery was more successful. So lots of times they do it that way as well.
Helping it, give it a little workout, like a minimal workout.
Yeah, just helps it relax a little bit. And again, too, if you are having downstream problems because cardiogenic shock, your mean arterial pressure is low, you're not perfusing everything else. By letting the heart relax a little bit, you're still ensuring that your tissue perfusion happens downstream as well. Or upstream, you know what I mean? Make sense? Okay, so there's those two videos. I couldn't find a good one where they were inflating the intra-aortic balloon pump, but that guy talked fast, but it still worked. Okay, so now we know what causes it, what it looks like, how to identify it. So here's the next question. How do you treat shock? Right? So it's going to depend on what the cause is. And it's also going to depend on what you have available to you, depending on where you are. So if you have low fluid, our tank is empty because of the hypovolemia, we are going to use IV fluids, right? So what type of IV fluids do you think you would use? Normal saline? Only normal saline? 0.5? D5? Okay, maybe dextrose? LR, lactated rigors. Do you see a lot of LR? Unless you do OB or OR, you probably don't. You could use some blood products, okay? So our most effective treatment is gonna be replace that volume, okay? How we do that, or we do our fluids first, and then eventually we're gonna have to follow with some blood products, but that's our first plan of attack is to increase the volume. For septic shock and cardiogenic shock, we wanna do IV fluids, not necessarily needing blood products. And definitely want to make sure we are careful on that cardiogenic shock, right? We don't want to overload it to the point where the heart has so much volume to pump, it can't do anything. Then it'll just shut down completely. Okay. When you are looking at fluid resuscitation, 2 large bore IVs or a central line. Okay, because you've got to get it in there quickly. Right? They have rapid infusers. Anybody ever used one? You can use it for blood, you can use it for fluid. You can hook it up and it will put an entire liter of saline in a matter of about a minute or 2. Right? It blows it in real fast. So you want to make sure you have as big access as you can, right? What's the biggest IV you've ever put in? 20. Anybody put in an 18? Those are the green ones. Great. 16 are gray, 14 are orange. Those are real big, but they work great. You can blow stuff in if you need to. Okay. So here's the two different types of fluids. The first one is crystalloid. This is probably what we think of when we think of IV fluids, right? We think of our normal saline, which is what we call isotonic, right? It's not going to pull fluid in. It's not going to try to get rid of fluid. It's going to maintain what we've got. So we have a fluid volume deficit. This is probably what we're going to see. Normal saline and lactated Rinners. What is the difference between the two? Do you remember, like, deep in the recesses of your brain ever learning the difference between the two? It does have some electrolytes in the lactated Rinners. It also has an affinity for oxygen. So we use that during OB and we use it in OR when we want to make sure we have optimal oxygen delivery. Okay, so if you ever wondered why you change out a bag of LR for your patient when they go to surgery, when they come back from surgery, you switch it back to normal saline, that's why. Okay, the other two kinds we're going to use are hypotonic and hypertonic. Okay, hypertonic is when you have excess fluid in the outside of the vein or the vessel and you want to pull it in, right? So remember, water follows salt. So this is an extra salty fluid that's going to pull water in and expand your volume. Okay. Hypotonic then is when you have too much on the inside and we need to kind of get it to the outside, right? Where fluid overloaded. So that's where we call it half normal or 0.45. And that's going to take it out of one area and it's going to pull it into the cells, right? So that we decrease a little bit. So depending on whether you want the volume on the inside of the vessel or the outside of the vessel, or you just want to maintain and not shift anything, but you just want to have more of it, this depends on what you're going to use. Okay. Have you ever given anything like had a starch or like 3% salines? Okay. You just have to be really careful with the hypertonic because it is super salty. It can cause cerebral edema. So we want to be real careful. When we're pulling things in and pulling things out, we just want to be careful we don't mess up the electrolytes. Okay.
Get that put you in that comments.
Huh?
The cerebral edema, can that put you in that coma?
Yes, cerebral edema can make it coma. Yep. There was a Worcester College football player who died of cerebral edema not too long ago, maybe a year or two ago. After practice, he hadn't been feeling well, so he chugged like, I don't know how many Gatorades and waters. And because there was so much of it, he was healthy enough and his lungs handled it. He didn't have pulmonary edema, but he had cerebral edema, right? And your skull acts like a brain helmet. Like it holds it in there. And so when your brain starts to swell, like there's nowhere to go, and he died. So you can mess up a lot of things if you're not careful. So here's kind of what a cell would look like based on what type of solution. So the hypertonic, right? It's going to kind of dehydrate itself because it's going to go out. The hypotonic, we're going to suck it in. Hypertonic sucks it in, the hypotonic pulls it out, and then isotonic keeps it level. Okay, so it matches what this is. Hypo, or maintains. You see that one, you can see that bioconcave, right, of the cell. Okay, so those are the fluids. The other thing that you can use is a colloid solution. And if you look in your book, there's a really good chart because there's a whole long list of different kinds. Okay, but what this is not just fluid or maybe some electrolytes that you're shifting back and forth across the membrane. This is a substance that can't go through that capillary. Okay, so this is the stuff. This is the sponge in your bloodstream, right, that holds all of the matter. It holds all the fluid. So we call these blood expanders, not necessarily fluid, but this is the meat. This is the sponge or the thing that holds it all together. So this is going to be your proteins, right, your albumins, your hetastarch, your plasma protein factor. These are going to be the things that you can give with our products. Here is a comparison chart. Okay, so here's the kind of things that are important. So it takes 3 times as much of the fluid to replace 1 of the colloid. Okay, so if you're given tons and tons of fluids, eventually you're gonna have to add some stuff. You're gonna have to add some protein, you're gonna have to add some head of starch, you're gonna have to add some plasma protein factor, something to kind of hold that water in, hold that IV fluid in, otherwise it's just gonna run back out, right? So think of these, like I said, as like the sponges that hold it together. Okay, these also are very inexpensive, and there's not a lot to be allergic to in a bag of IV fluid. Okay, whereas in the colloid solution, there is some components, right? Some protein or something that they could be allergic to. Okay, and then also if you have someone who has some cultural, dietary, religious type of practices that they follow, IV fluids are pretty safe. Whereas the colloid solution, depending on where it's derived from, might have some implications with it. Okay, so there are some religions and cultures that will not take blood products, or won't take a pork product, or won't take a whatever it is, right? So you just have to know that. Okay. We doing all right? Okay. All right. Other 2 things we want to use when we're talking about distributive shock. Okay, especially, we use it for everything, but let's think distributive especially. If the problem is that fluid is, or all the blood is out in the periphery, right? If we vasoconstrict it, if we take that lumen and we shrink it, it then increases the blood pressure, right? And it gets back to the heart and get back to the pump faster. So anybody ever seen Levophed used? Norepinephrine? Okay. When I first started in nursing, we used norepinephrine so scarcely. We did Levophed and we'd say, or we could leave them dead because like it was a last ditch effort, right? So now though, we're finding that if we introduce these vasoconstrictors earlier, it's a better outcome. Okay, so it used to be we were really hesitant to use these. Now we use them all the time. We still have the effect with these though, where we are going to vasoconstrict starting in the periphery and then pushing that blood in, right? So fingers and toes, sometimes from the elbow down, sometimes from the knee down, you are gonna get massive vasoconstriction depending on how long it's used, depending on how high it's cranked up to keep that MAP above 65. So you do have the risk of poor perfusion to the periphery. And then you have the vasodilators. Okay, we're going to use those when the body's natural response is to clamp down, but that's making it too hard on the heart to pump, right? So we've got to open it back up so that the pump can work better. Make sense? Well, you would use the 2 different ones. Okay, so I highlighted, we use nitro all the time. We talked about that with acute coronary syndrome. We talked about that. Nitro is the first line response for what? Angina. Right, stable angina, and what's the other kind?
Oh,
Prince metal, the vasospasm, right? That's what we use the nitroglycerin for, right? Because it vasodilates everything open. Okay, so we can do it in a drip. Milrinone is another one we can use. So just kind of be familiar with what those do and why we would use them. Okay, and then the other one, other category is an inotrope. Right? What do we know is an inotrope that we talked about the last couple weeks? Digoxin. Digoxin, okay, we also have dopamine and dobutamine. Okay, so these will strengthen the heart muscle itself and increase the cardiac output. So depending on what type of shock you have, whether it's a tank problem, a pump problem, or a peripheral problem, we know what type of medication we can use, right? And it's not a one category is only for this type of shock. It's a mix and match, but just understand why we would use it. You with me so far? Are we worried about the test? Worried about the test, okay. I see some people looking a little anxious at their watch and some people are trying real hard to stay awake, so I get it, I get it. All right, other medications we're gonna use. Diuretics, why are those important? You take off the fluid. Tell me what types of diuretics there are. Potassium sparing and loop, right? If it is potassium sparing, do we have to worry about the potassium level? What if it's loop? Which one do we want to be more concerned about, the potassium level? Loop diuretic. Give me a generic name of a loop diuretic. Furosemide. Yes, absolutely. What happens if you push furosemide too fast? Ototoxic. You're gonna cause ringing in their ears and possible some hearing damage.
Pushed Lasix for the first time yesterday. That's the only reason why.
Well, there you go. Perfect. Yep. All right, calcium. Right? We want to make sure that we medicate with calcium. If we're doing lots of replacement of blood and fluids, we want to make sure that that is good. Why is calcium important? What's that?
And it helps your heart pump.
It helps your heart pump. We have calcium channel blockers, right? So calcium's important. Tell me a calcium channel blocker. Amlodipine. Okay, good.
Is this for all for shock or just the distributed?
All, these could be for all of them. These are just meds we use, okay? Antiarrhythmics, we use those, right? We want to make sure that we keep the electrical system going well. Broad spectrum antibiotics, and again, it says, make sure you draw the blood cultures before you give the antibiotics. You only get yelled at your charge nurse one time and you will never forget that. And then our antihistamines and our beta-2 agonists, those are for our respiratory conditions and our immune responses. Okay. For specifically our obstructive and cardiogenic shock, we got to figure out what the cause is, right? Do we need to take them to the cath lab? Do we need to give a fibrinolytic? Do we need to pull some fluid off the heart because it's being smushed with a tamponade? Do we need to give an inotrope to try to make it squeeze better? Or do we need to do something that try to get rid of that afterload or the pressure that it's pumping against, right? So we got to figure out what's causing it and then fix it that way. Hypovolemic, same thing. You might have to go to the OR, right? We'll talk about that in a minute when we talk about trauma. You might have to go to the OR because if there's bleeding and you can't see it and that hemoglobin and hematocrit are dropping, the blood has to be going somewhere, right? So we'll take them to the OR or maybe we'll treat what's causing it. We use our volume replacers, whether we're going to use our crystalloids or our colloids. We're going to make sure we do lots of hemodynamic monitoring or using vasopressor medications. And we're going to use life support, okay? If for some reason they are to the point where, and with any of these shocks, that they are approaching the coma level of consciousness, we cannot just let them breathe on their own. Right? They're going to lose their gag reflex and we're going to choke. So we need to make sure that we are ready for any type of airway emergency. Distributive, because this is such a big category, each one is then kind of put in its own category here. So anaphylactic, we know we use epi, right? Tammy had her EpiPen in her purse. We use our steroids. We use our bronchodilators, okay? If it's neurogenic, we got to treat whatever is causing that irritation to the nervous system, right? Whether it's a bladder that's too full, whether it's a fever, whether it's, whatever it is. And then for septic shock, we use antibiotics, fluids, all the things. When they are decompensated, as they're approaching that progressive, right, in transitioning from the compensatory to the progressive, got to make sure, again, we are trying to keep the MAP above 65 and we are making sure we have all that airway stuff ready. Okay. Last thing, what's our responsibility as nurses in this, right? Can we write the orders? No. Can we assess? We can assess the hell out of them. We can call people. That's what we can do, right? We look at that oxygen status. That's our priority, right? Remember, shock is a perfusion problem. It's an oxygen delivery problem, okay? We can make sure we are keeping an eye on all this stuff. Accurate charting. We want to make sure we do not need a doctor's order to put the crash cart outside the room. We do not, but we can be ready, okay? And then again, we can also position them, right? We don't need an order to say, put them in Trendelenburg for a hot minute or to lift their legs up, okay? Questions on that? Yes.
I do have a question on your slide, on like slide 16.
Okay,
I just saw it, I was writing my notes.
16, all right. Okay,
Wait, this next slide, actually, sorry. In progressive, you put slightly increased blood pressure Wouldn't it be decreased? The slide before said decreased.
It will, but it also will increase before it decreases. So the change in vitals, remember that compensatory, so this says progressive, but it's actually both of them. It's a compensatory and progressive. So originally you might have an elevation in heart rate and blood pressure, and then it will fall. That's why. Sorry, that was confusing. Anything else that doesn't make sense? Okay, we are going to take a quick break and then we're going to talk about trauma. We're talking about gunshot wounds and knives and abdominal blunt things and ribs that pop out and.